Today, we have Saul Sanders, a 61-year-old male that was admitted to the ER on 4/21 of 2024, with his chief complaint of "my wound is not healing." With a history of patient information, the SS is a 61-year-old male who presents to the ED on 4/21 with the lower left extremity feet ulceration, necrotic in nature, after a referral from his wound clinic for a chronic wound that wasn't unresponsive to therapy. Therefore, patient is not ambulatory at baseline but can occasionally move. His past medical history is type 2 diabetes with peripheral neuropathy, hypertension, hyperlipidemia, peripheral vascular disease, and chronic kidney disease with a baseline serum creatinine of 2.9. With surgical history, the patient had a left prosthetic hip replacement occurred 2 years ago. For social history is non-contributory. For family history, his mom is deceased from diabetes. And for allergies, patient is allergic to Bactrim, which is sulfamethoxazole trimethoprim, which occurs with rash, and Lipitor, which is atorvastatin, and reports having rhabdomyolysis 6 months ago. For home medication for type 2 diabetes, patient is taking Humalog 34 units 3 times a day and Jardiance 10 milligrams every day, gabapentin 300 milligrams twice a day, and for his peripheral vascular disease, patient is taking aspirin 81 milligrams every day and lisinopril 20 milligrams every day. Reviewing his systems, patient presents with fever, slight chills, and left foot swollen with multiple ulcers, otherwise negative as stated per HPI. For vital signs, we have an elevated blood pressure at 141/76, a temperature elevated at 101.1 that tells us that it could be a fever. Other vital signs were within normal limits. Patient's weight is 79.4 kilograms with a height of 5 feet and 11 inches. While looking upon the physical exam, we see a male in mild distress. The left foot shows necrotic ulceration at multiple locations at edema, exudate, and erythema with ulcers more than 3 centimeters squared. Otherwise, within normal limits. For the labs we see was elevated white blood count at 18,000, elevated glucose at 271, high serum creatinine at 2.9, alkaline phosphatase low of 45, and a high C-reactive protein of 7.2, and a high erythrocyte sedimentation rate of 62 millimeters per hour that can indicate an inflammation. From that day, the patient, the doctor started empiric therapy and ordered an X-ray and MRI. The patient was then started for ID medications of vancomycin, 1 gram IV every 24 hours, and piptazo of 4.5 grams IV every 8 hours. And then the patient was also started for his diabetes, which was Humulin R. The labs did return back on that day for his cultures. 2 blood cultures was retrieved from the right arm and the left arm. Both gram stains was aerobic. From the both aerobic and anaerobic was gram positive, cocci in clusters, with both susceptibilities from the left and right arm. Report shows Staphylococcus aureus. With the susceptibility reports, it was resistant to oxacillin, ampicillin, and sulbactam, and erythromycin, and susceptible to daptomycin, linezolid, Bactrim, doxycycline, and vancomycin, with the MIC of equal to 1 microgram per milliliters. They did order the X-ray of the left foot of 4/21, and it showed a destruction of the lower left distal phalanx, extensive vascular calcification. On progress notes from day 2, Patient underwent a surgical debridement of the foot that morning, and amputation is being considered. The patient is reporting no pain, however, fever remains persistent, therefore they requested a podiatrist consult. For a assessment and plan from then, they wanted to continue Peptazo and vancomycin, but ordered a trough, and continue the Humulin R, restarted the clopidogrel and aspirin, and then referral for hyperlipidemia since there was no medication necessary. On day 3, which is today, the podiatrist returned with the referral and saw the physical exam was wound on the left foot and at advanced stage decay. Affected area is black and gangrenous with minimal discharge from the wound post-debridement. From diagnostic, as mentioned, from 421, the X-ray showed vascular calcification. The MRI ordered from yesterday showed abnormal enhancement involving the proximal phalanx and distal phalanx of the left fourth and fifth toe, consistent with osteomyelitis. Then, the podiatrist recommended the transmetatarsal amputation of the left foot later that afternoon. In seeing the trends with the vital signs and the labs, since day 1, the vital signs of the blood pressure has normalized to 127/76. The pulse has been stable since day 1. The temperature is still persistent for a fever, which is today at 101.4. Respiratory rate has been stable at 17, and O2 stat has also been stable at 98% at room air. White blood count has decreased slightly, but now stable at still elevated, stable at 16,000. Glucose has been trending down, but still elevated at 158. Well, we want to consider the BUN is high at 33. Serum creatinine stable at around ranging from 2.9 to 3. Alkaline phosphatase at 44. And the vancomycin trough was returned at 13 micrograms. So with the primary problem that we have here today, we have the complicated bacteremia secondary to osteomyelitis. Key evidence shows the recent surgical history of the hip replacement for 2 years. We have a blood culture that was positive for both left and right arm that showed Staph aureus. We also have the labs elevated at ESR and an elevated CRP, and we also have a persistent temperature of 101.4. For therapeutic goals, we want to eradicate the organism with optimal therapy while minimizing therapeutic failure and potential for resistance. We want to relieve the signs and symptoms associated with the infection, including the bacteremia, and find the source of the infection. Other than that, we'd love to reduce the morbidity and mortality and maintain hemodynamic stability as well. For plan, we're going to stop Peptazo and stop vancomycin, and instead we're going to start daptomycin with a dose of 8 milligrams per kilograms. So daptomycin 800 milligrams IV every 48 hours for 6 weeks, with day 1 is when we first have the blood cultures as negative. For non-pharmacological goals or therapy, we'd like to repeat blood cultures every day or every other day until negative. And for efficacy parameters, we want to check for white blood count and the temperature, as well as the ESR and the CRP in response to the antibiotics. For safety concerns with daptomycin, we want to look at the serum creatinine and the creatinine clearance, and the CK and CPK weekly to see signs and symptoms of muscle pain and rhabdomyolysis. Thank you.